My name is Cindy Law. I'm a gastroenterologist at the Crohn's and Colitis Center at MGH. Thank you so much for the opportunity to speak today. My presentation will be about diagnostic testing and monitoring in IBD. So let's start with how to diagnose IBD. So as we all know, IBD is a chronic inflammatory condition of the gastrointestinal tract, which includes Crohn's disease and ulcerative colitis. And this table outlines key characteristics of these two conditions. Crohn's can affect any part of the GI tract, from the mouth to the anus, while ulcerative colitis is limited to the colon. In addition, inflammation in Crohn's can be discontinuous or patchy, while UC typically starts in the rectum and is contiguous. Patients present with symptoms such as abdominal pain, diarrhea, and rectal bleeding, but the presentation can be highly variable depending on the location of the inflammation. As Crohn's is a transmural disease, it can also result in complications such as fistulas and abscesses. UC can result in complications, including toxic megacolon and increased risk of colon cancer. And lastly, we must also consider extraintestinal manifestations, which can occur in both Crohn's disease and ulcerative colitis. The most common EIMs affect the skin and the joints. So the initial workup of someone who you suspect to have IBD begins with a detailed history and physical exam. In general, the history should include past medical history, medications, social history, symptoms including extraintestinal manifestations, symptom duration and severity. Initial blood work should include a complete CBC to assess for anemia and leukocytosis, comprehensive metabolic panel to look for electrolyte and liver abnormalities, and CRP, which is a marker of inflammation. And as Kevin mentioned earlier, around 15% of patients don't mount a CRP response, so we cannot rely on CRP alone. Stool tests are also very important to rule out infectious etiologies such as C. difficile. Obtaining a fecal calprotectin can also be helpful. It is a marker of intestinal inflammation, and in patients where the diagnosis is unclear, it can also help differentiate between IBD and non-inflammatory conditions such as IBS. It is also helpful to have a baseline calprotectin so that it can be repeated down the line to monitor response to therapy. And then there's endoscopy. Colonoscopy remains the gold standard for diagnosis. It allows us to assess disease extent and severity, and to also obtain biopsies to confirm the diagnosis and rule out mimickers of IBD, which you learned about in the previous presentation. As mentioned earlier, in ulcerative colitis, we typically see continuous inflammation starting in the rectum, and endoscopic features would include decreased vascular pattern, mucosal friability, and ulceration. In contrast, in Crohn's disease, inflammation is often patchy, and you would see features such as aphthous ulcers, deep ulcerations, cobblestoning, and strictures. Another key feature of Crohn's disease is ileal inflammation. Around 70% of patients with Crohn's disease will have ileal disease. We use a number of scoring systems to objectively assess the severity of inflammation seen on endoscopy. There's a number of scoring systems used, but I most commonly use the Mayo Endoscopic Score for UC and SESCD for Crohn's disease. Mayo score ranges from 0 to 3, 3 being the most severe, and SCSCD ranges from 0 to 60. And while colonoscopy is essential for all new diagnoses of IBD, EGDs are usually indicated only in patients who have upper GI symptoms. In many cases, as I mentioned, colonoscopy with terminal ileum intubation is sufficient for diagnosis. However, when Crohn's disease is suspected, we need additional imaging of the small bowel. So cross-sectional imaging such as CT or MR enterography is recommended in these cases. In younger patients, MR is preferred to avoid radiation. Capsule endoscopy can also be used in certain cases to diagnose small bowel inflammation. However, it is very important to rule out strictures beforehand to avoid capsule retention. And this can be done with a patency capsule study or other imaging tests. So after the workup is completed, the complete phenotype of the disease can be described. Some providers use the Montreal classification listed on this slide, while others prefer to describe the phenotype in words. The components of the Montreal classification system includes age of diagnosis, distribution of the disease, and in Crohn's disease, the behavior as well. So whether it's a stricturing disease or penetrating, and whether there's perianal involvement. And regardless of the method that you choose to use, it is very important to include in every note the disease phenotype as it guides decision-making and risk stratification. So before I move on to the second half of the presentation, I'll pause briefly just in case anyone has any burning questions. Okay, so no questions at this time. So let's move on and discuss how to monitor disease activity over time. We have many ways to evaluate patients' disease activity. Historic treatment strategies have focused on resolution of symptoms. However, it's important to recognize that symptoms alone are not reliable indicators of inflammation. You may have seen this in your clinic. Sometimes a patient is found to have Crohn's disease incidentally on a screening colonoscopy, and is completely asymptomatic. Conversely, other patients may report significant symptoms, but have only modest inflammation when scoped. A study published by Sellier and colleagues in 1994 confirmed that clinical symptoms often don't correlate well with mucosal inflammation. The scatter plot on the left compares the Crohn's disease activity index and the Crohn's disease endoscopic inflammatory score in 121 patients. And the correlation between the two was found to be quite weak, only 0.32. So while important, symptoms alone cannot guide management decisions. The CALM study was another pivotal study, and it demonstrated that objective monitoring is critical in managing IBD effectively. It was an open label, multi-center RCT in which 244 patients with Crohn's disease were randomized to either tight control or clinical management groups. The tight control strategy used symptoms and biomarkers such as CRP and calprotectin to guide decision making, while the clinical management group used symptoms alone. The primary endpoint was mucosal healing with absence of deep ulcers 48 weeks after randomization. And as you can see here, the results showed that a significantly greater proportion of patients in the tight control group achieved the primary endpoint compared to the clinical management group. So building on this knowledge, the STRIDE 2 guidelines provide a comprehensive framework for disease monitoring. The treat to target strategy integrates clinical symptoms and improvement in quality of life and disability with objective markers of intestinal inflammation. And treatment targets are categorized into short, intermediate, and long-term goals based on the time since therapy initiation. So the time frames for short, intermediate, and long-term targets do vary based on the medication used. Some are slower in onset than others. But typically, when we refer to short-term outcomes, we mean within the first 3 months of treatment. Short-term outcomes include symptomatic response. So in this time frame, patients should start to feel better, although not necessarily back to their previous baseline. For example, they may notice fewer bowel movements, less bleeding, or improved urgency. When we can use indices like the Harvey-Bradshaw index for Crohn's disease or the partial Mayo score for ulcerative colitis to quantify symptom burden. The components of these scores are listed here for your reference. The partial Mayo score for ulcerative colitis includes stool frequency, rectal bleeding, and an overall global assessment score. The Harvey-Bradshaw index for Crohn's disease includes stool frequency, abdominal pain, a general well-being score, presence of complications, including extraintestinal manifestations, and the presence or absence of an abdominal mass. So some centers formally calculate these scores at every clinic visit. However, at MGH, I don't do that, but I will use the components of these scores to guide what questions I ask patients. So next, in the intermediate time frame, which is usually 3 to 6 months, we aim for symptomatic remission and normalization of biomarkers. Symptomatic remission is defined as achieving a Harvey-Bradshaw index below 5 or a partial Mayo score under 3 with no subscore above 1. So, however, we don't stop there, as we know that the resolution of symptoms alone is not a sufficient target. So we look at the biomarkers. CRP should be within the normal range, and fecal calprotectin should ideally be under 100 to 250 micrograms per gram. And personally, I target under 150. And ultimately, in the long term, meaning 6 to 12 months after starting therapy, our goals are first, endoscopic healing, secondly, restoring quality of life, and third, the absence of disability. Endoscopic healing is critical as it has been shown to be associated with improved long-term clinical outcomes, including sustained clinical remission, reduced hospitalization rates, and decreased need for surgical intervention. To determine endoscopic healing, the STRIDE-2 guidelines recommend repeating the endoscopic assessment 6 to 9 months following initiation of a new therapy. Endoscopic healing for Crohn's disease is defined as an SES-CD score of under 3 or the absence of ulcerations. And for UC, it's defined as a Mayo score of 1 or less. However, a Mayo score of 0 is preferred as it has been found to be associated with superior disease outcomes. So in rare cases where endoscopy cannot be performed, for example, if someone has a stricture at the ileocecal valve that cannot be traversed, so the terminal ileum cannot be assessed, imaging should be obtained. And beyond mucosal healing, as I mentioned before, other long-term targets include restoring the patient's quality of life and ensuring that they can resume their normal activities. And from a patient standpoint, this is probably more important to them than endoscopic healing, which is a more abstract concept. In quality of life, we can measure it formally using scores such as the short IBD questionnaire, and disability can be measured using the IBD Disability Index or the IBD Symptom Index. So in recent years, there's been growing interest in novel tools for disease monitoring. One such tool is intestinal ultrasound. That's a topic that I'm passionate about and regularly use in my clinic. On the right is an ultrasound image, and it is showing a segment of inflamed bowel. You can see that the bowel wall is thickened, and you can see the red and the blue dots, which demonstrate hyperemia. Intestinal ultrasound has gained popularity in North America due to its non-invasive nature, the ability to perform it at the point of care setting, and it is very useful, especially for making real-time clinical decisions. It's quick, maybe taking 10, 15 minutes to complete. It requires no fasting or bowel preparation and is thus both convenient and safe for both adults and children. So studies have shown that IUS correlates well with endoscopic findings as well as cross-sectional imaging. And in addition, other exciting technology on the horizon, there's research into wearable devices and sweat sensors And hopefully one day we'll be able to offer real-time data on disease activity and perhaps predict the onset of flares. So to wrap up, let's go through a clinical case so we can apply the concepts that we've discussed this morning. I'd encourage you to participate. I can't see the comment box, so please feel free to turn on your microphones and jump in if you have a question or a comment. So John is a 27-year-old man. He has no significant medical history. He takes no medications. He presents with 3 months of bloody diarrhea, urgency, and a 15-pound weight loss. On exam, his vitals are stable, although his abdominal exam does reveal some mild right lower quadrant tenderness without guarding. So if you saw John in your clinic, what investigations would you want to order?
BBC, CMP, sed rate, CRP, maybe infection, stool studies, and a calprotectin.
Yes, very good. So I don't know who was speaking earlier, but I agree. So it's very important to rule out infection. So the C. diff, the GI-PCR, the calprotectin is also very important because we can use it to confirm that there is an inflammatory cause going on, and also as a baseline so that we can track it over time. Is there something else that we might order in addition to the blood tests and stool tests that were mentioned?
Colonoscopy.
Yes, uh, very good. So the colonoscopy was ordered, and here are some images from the colonoscopy. You can see here on the left is image from the colon, on the right, the TI. So you see deep linear ulcerations throughout the colon. There's also an ulcer in the TI. The histology reflects moderate to severe chronic colitis throughout the colon and terminal ileum. So given these findings, what would you do next?
If I'd work for a biologic start.
Okay, that's a good thought. Biologic start, yes. Any other investigations, particularly to help us determine the full phenotype of disease?
Yeah, you'd somehow want to assess the small bowel.
Yes, yes. And what are the options, or what modality might you want to order?
I would
MRE?
MRE.
Okay, yes, MRE is a good choice. So, as mentioned before, you can use either like a CT interrography, MRE, or even capsule endoscopy to assess the small bowel. But in this patient, given his age, MRE was ordered just to avoid further radiation exposure. His MRE showed skip lesions and an ileal stricture. So putting it all together, the workup confirmed stricturing ileocolonic Crohn's disease, and the patient was started on infliximab. So 3 months later, he comes back. John is feeling so much better. He's having 1 to 2 formed stools a day without blood. He denies any urgency or abdominal pain. He's very happy because he's been able to return to work and has no limitations in his daily activities. And at this point, what would you do?
If available, you could do intestinal ultrasound, or you could do non-invasive markers of CRP, fecal calpro, and repeat colonoscopy in 6 to 9 months.
Okay, perfect, perfect. So John's CRP and calprotectin were normal. And here are images from his repeat colonoscopy. The ulcers that we previously saw in the colon and the TI have healed now. The colonoscopy demonstrates endoscopic remission, and the SES-CD score is 0. As well, the biopsies of the colon and the TI were normal. Okay, so to conclude, I'd like to summarize the key takeaways from today's presentation. When diagnosing IBD, it's essential to assess clinical activity, determine disease extent and severity, identify the presence or absence of small bowel inflammation and extraintestinal manifestations, and also obtain baseline inflammatory biomarkers. When monitoring disease, remember that symptom resolution alone is not sufficient. We must confirm healing objectively, and the treat to target approach is currently the gold standard for management. The information presented today is based on adult GI guidelines and practices. I realize that some of you here work in pediatrics, so I wanted to mention that different classification systems and disease activity indices are used in the pediatric populations. I've listed them here for your reference.